video fine? Is audio video fine? All my dear students listening to me, can we start with the session? Can we start with the session? All the students, is audio video everything fine? Very good evening. Can you update in the chat box? Is audio video fine? Yeah, thanks for the update in the chat box. So, beta, myself, Dr. Deepak, on this platform of DAMS, I will be trying my best. First of all, beta, just I want one, before starting the session, I want one promise from you. Every student sitting with me, next few days, we will work 24/7, beta. Samajh mein aa raha hai? Are you getting this point? No negative thoughts. Whatever we have, many students, we are getting many inbox messages, okay, sir, what to do, what to not to do in the next 5-6 days before your before your examination. Just remember this point: do whatever you want, try to give your best performance. Am I understandable? Are you getting this point? अगर अभी तक कुछ भी नहीं पढ़ा, take my word, कुछ याद नहीं आ रहा, is but normal phenomena before examination, बेटा. It is a normal phenomena. Am I understandable? Are you getting this point? So just do one promise: don't quit before the examination. Just be confident. Last few days, work 24/7 and just revise whatever you have learned. Some students, sir, what is the strategy? What should be the strategy? In the last few days, short subjects will be the game changer. Just focus your eyes on the short subjects. Try to revise. Strike rate is very high. I will be able to attempt all the 10 of the 10 MCQs of ENT. So it is better we should focus on the short subjects. So clear? So if you ask me in the next few days, so till your one day before the examination, just try your best to go for short subjects. Am I understandable? Are you getting this point? This will be a game changer. Last day before the examination on 4th of March, just have a sound sleep, go with a full confidence and appear for the examination. Am I understandable? So let us use this platform. I will be using this platform to revise all the important topics of ENT so that you can manage to crack most of the MCQs of ENT. I'm confident all the students who have attended my lecture before, they will be, this will be a fast revision for them. And those students who are listening to me for the first time, even then, better just make a note of the MCQs, note of the topic which I'm sharing with you. Clear? The first slide I'm showing you is here. Lateral wall of nose. Lateral wall of nose. So be confident, beta. This is your inferior turbinate. This is middle turbinate. What is the importance of inferior turbinate? Is the most common site for hypertrophic rhinitis. So if the examiner asks you most common site for hypertrophic rhinitis, what will be the right answer? Inferior turbinate. Inferior turbinate will be the most common site for hypertrophic rhinitis. Middle turbinate, what will be the importance of this middle turbinate? Middle turbinate, just everybody, concha billosa. So concha billosa. In concha billosa, the most common turbinate involved is your middle turbinate. Then what examiner can do? Examiner can ask you which important sinus open here. So just above the middle turbinate, which sinus will be there? Posterior ethmoid. Just below the middle turbinate, I will be having 4 important sinus which should be on your tips. And if examiner asks you, I just want everybody should respond in the chat box. But you tell me which important sinus in the supreme meatus, in the uppermost meatus will be my, very good, very nice. But everybody is responding in the chat box is a very positive sign. Everybody is responding. One of the student, Dr. Priya, is asking most common cause of CSF rhinorrhea, surgical trauma beta. It is iatrogenic surgical trauma. Na? So the examiner will not give you both the option trauma and iatrogenic. No. And if given, go for iatrogenic. It is your surgical trauma, endoscopic trauma, most common cause of CSF rhinorrhea. Very good, very nice. So all important tabinets should be on your tips. Am I understandable? What they can ask you, this is which bone? This is sphenoid bone. Which part of the sphenoid bone is contributing in septum? Just remember, this part is contributing, which is known as rostrum. Just remember, beta, it is rostrum of sphenoid, which is contributing in your nasal septum. One important point, I want you will be getting all this PDF important points, but just remember, making note of the important topics which should be revised thoroughly before the examination. The next slide, I am showing you important air cell. If they ask you the most posterior, that is your anode cell. Anode cell is the most posterior, very close to optic nerve. Most posterior is your anode cell. Just remember this point. Clear? Is your anode cell. And if the examiner asks you something on the floor of orbit, this will be Haller cell. On the floor of the orbit will be Haller. Clear? And if the examiner asks you most posterior, that will be anode cell. That will be anode. Done? Very simple. Then examiner can ask you the most anterior. What is the most anterior? Just remember, the most anterior is your agoneza. Most anterior will be your agoneza. Just remember these points. I'm briefing all important MCQs expected for your examination. Clear? Done? Agoneza. And if examiner asks you a big large air cell, what is a big large air cell which is there in the orbit and nasal cavity, between nose and the orbit? This is your large air cell known as bulla ethmodalis, Done? So these are the important. So which is the next topic which you people should write? 4 ethmoidal air cell. You should be aware of agoneza, bulla ethmodalis, anode, agoneza. O for anode, O for optic nerve. It is very close to optic nerve. Am I understandable? Then examiner can ask you which of the following turbinate is very close to palate. So just remember, close to palate will be your inferior turbinate. Close to palate will be inferior turbinate. Done? So these are the important points related with important ethmoidal air cell. Now I am showing you one slide. Now concentrate on this book. In first slide, I am showing you some perforation. I am showing you some aperture in the palate. You people tell me if there is some opening in the palate. If there is some opening in the palate, there is an aperture. Can I call it as rhinolea aperta? So beta, how will be the voice of this patient? Rhinolea aperta. The nasal component will increase. So what we call it as? We call it as hypernasality. So एक word याद रखेंगे बेटा, it is hypernasality, rhinolea aperta. And if they show me some obstruction in the nose, like there is some inferior turbinate hypertrophy, if there is any obstruction, I will be going for hyponasality. What we call it as rhinolea closa. So beta, just remember two important terms: rhinolea aperta, rhinolea closa. These are the two important segments which should be on your tips. Clear? So after learning these important rhinolea closa, rhinolea aperta, one MCQ I am expecting this year on endoscopy. So I am just writing important points. Endoscopy, most common complication of endoscopy. Just remember, synecdoche formation. Mitomycin C is used. Treatment will be surgical. Clear? CSF rhinorrhea can be a complication, like Dr. Priya was asking. It is here iatrogenic trauma. Very rare complication of endoscopy is your retrobulbar hematoma. And what your NEET people can ask you, it is due to injury to which artery? So just attempt, it is anterior ethmoidal artery. Which endoscope is commonly used in nose? Just remember, 30-degree endoscope is commonly used in nose. Am I understandable? Mitomycin C, very important topic for your NEET examination. They can show you a vial, they can show you the drug mitomycin, and they will ask you which is the important indication. In ENT, I'm talking about, one will be synecdoche formation, The other possibility, it is used in nasopharyngeal carcinoma. Just remember, it is used in nasopharyngeal carcinoma. It is a drug of choice for synecdoche formation. And the third indication, anyone who can write in the chat box, I'm confident everybody will respond. Yes, one is subglottic stenosis, not, it is antifibrotic. Absolutely right, beta. Dr. Javed, excellent. Subglottic stenosis, it can be even used for, instead of grommet, we can use in myringotomy. So just remember three important indication, myctomycin C, myringotomy में use कर सकते हैं बेटा, synecdoche formation and nasopharyngeal carcinoma. So these are the three important indication of myctomycin C. Myctomycin C, done. Coming to the next level, passes. What are the three important passes of endoscopy? Like in the first pass, we examine inferior meatus, first pass. What is first pass? First step. In the second step, we appreciate superior, supreme and anterior part of middle meatus. In the third part is your posterior part of middle meatus. The only aim of conducting this session, beta, just fast revision. It will help you in the examination hall. All these are the key topics which are repeated again and again. Clear? So these are the important MCQs related with endoscopy. These are related with endoscopy. Coming to the next segment, what I'm showing you a mulberry. What is the importance of this word mulberry in ENT? Just remember, mulberry like mucosa, mulberry like polyp. If examiner asks you about mulberry like mucosa, what is mulberry like mucosa? Is hypertrophic rhinitis. Hypertrophic rhinitis लिखेंगे बेटा. And if examiner asks you about mulberry like polyps, it is your rhinospodiosis. It is rhinospodiosis. These are the two important MCQs expected. Mulberry like mucosa, mulberry like polyps. Am I understandable? Clear? So can I make some differential diagnosis now? Now let us start. Examiner giving you option of foul smelling crust. If in the MCQ, if there are foul smelling crust, so beta हम क्या सोचेंगे? We will, what our eyes will be searching for. Eyes will be searching for the word anosmia. If anosmia is there, it is merciful anosmia. If anosmia, word merciful anosmia, we are talking about, yes, you people should tell me, it is atrophic rhinitis. It is atrophic rhinitis. Expected MCQ in the upcoming examination. Foul smelling crust with merciful anosmia. Beta, these flowchart, these keyword will help you a lot. Am I understandable? And in the examination, beta, I will give you the most important point which you should remember: time management. Keyword, time management. Don't stuck to one MCQ. Focus on the keyword. Don't get confused. Last NEET examination, they have given the word merciful anosmia in the last statement. So sometime we can manage to crack the MCQ with the help of last statement only. So just make a habit. Just thumbs up in the chat box, beta. We will read the last line first. Just read the last line. It helps a lot. Sometime out of 200 MCQs, 4 or 5 MCQs we can manage even with the help of last line only. So just try to do this. If the word merciful anosmia is given, I will be going for atrophic rhinitis. And which keyword he will be asking? He will be asking you which cavity. If everything is atrophied, it will be roomy cavity. Beta yaad rakho, everything is atrophied. If everything is atrophied, it will be roomy cavity. Clear? If the examiner will use the word woody nose, if the word woody nose is there, it is for rhinoscleroma. So just remember, beta, if the word atrophic rhinitis, merciful anosmia and woody nose will be rhinoscleroma. I hope you are getting this concept. What is common between these two? Common between these two is your Klebsiella. Therefore, whether it is rhinoscleroma or it is atrophic rhinitis, my drug of choice will be streptomycin tetracycline. This type of people, absolutely crystal clear. Keywords should be on your tips, beta. All the concepts should be very crystal clear if you want a decent rank in the examination. I understand. And last few days, don't create any unwanted pressure of top ranks and everything. Nothing, beta. Whatever you have studied, just give your best performance. If examiner use the word unilateral, what the word unilateral is used in ENT where? Unilateral foul smelling nasal discharge. If examiner use this word unilateral foul smelling nasal discharge, he is talking about rhinolith. What is rhinolith? Rhinolith is your foreign body in the, oops, very good, very nice. Everybody is responding very fast. Unilateral cervical lymphadenopathy. If this word is there in the ENT, cervical lymphadenopathy, I will be going for nasopharyngeal carcinoma. Nasopharyngeal carcinoma. Am I understandable? So unilateral foul smelling discharge, rhinolith. Unilateral cervical lymphadenopathy will be your nasopharyngeal carcinoma. So this is the importance of your Mulberry word in ENT MCQs. Coming to the next slide, what I am showing you, this is anosmia. Anosmia word will be, one will be in atrophic rhinitis. Yes, it will be in atrophic rhinitis. Second, it is a feature of COVID symptom. COVID anosmia is one of the prominent symptom. Just remember, anosmia can be seen after laryngectomy, post laryngectomy. Anosmia can be there. Why? Because the airflow is gone from the nasal cavity. The airflow is coming from the trachea now, tracheostomy. So post laryngectomy, it will be seen. One of the students is asking me about ABC, absolute bone conduction test, Schobert. I will be touching the topic of audiometry, I'll be teaching you this point. So anosmia post laryngectomy, just remember COVID. Very nice, Dr. Abhishek beta. If examiner asks you the most common ENT manifestation of COVID, it is not anosmia, it will be sore throat. Just remember this point. No, most common ENT manifestation, most common non-ENT manifestation, obviously it will be fever. Am I understandable? ENT will be fever, ENT will be sore throat. Anosmia is not the most common. Just remember this point. Now, after learning this, I am showing you one important slide. What is this? This is nasal fracture. This is your nasal fracture. What is the importance of nasal fracture? Is the most common facial bone fracture. It is the most common facial bone fracture. Done. It is most common facial bone fracture. Which is the second most common fracture? Second most common fracture is zygomatic fracture. Second most common will be zygomatic fracture. Just remember. And what is the other name of zygomatic fracture? We call it as tripod fracture. Just remember, tripod fracture. Zygoma fracture, second most common. That is your tripod fracture. Clear? What is the mnemonic for zygomatic fracture? Is T square. What is T square? T square means tripod fracture, and one is teardrop sign. So when there is a fracture in the zygomatic arch, there is a chance of teardrop sign. There is a chance of teardrop sign coming. What is a golden rule? I'm writing in capital letter. Facial fractures, nasal bone, or whether it is zygomatic fracture, just remember, facial fracture should be reduced immediately. Why? Because edema will be there, and if edema is there, you cannot appreciate facial symmetry. So what is the golden rule of facial fracture? Golden rule of facial fracture, we should reduce immediately. But if edema is there, then what to do? If edema is there, just remember, we will give anti-inflammatory and we will reduce after 5 days. Done. Now, what is close reduction? What is open reduction? Patient coming from a remote village. If he's coming in your emergency after 3 weeks, we have to go for open reduction. And if the patient is coming within 3 weeks, I will go for close reduction. These are the important points related with facial fracture. One MCQ expected on this topic. Clear? Coming on, I will be hitting one controversy. There is a septal abscess, septal hematoma. So if the examiner is giving you septal hematoma, what will be the next treatment? Obviously, the patient is having difficulty in breathing. I will go for IND. I will be draining that hematoma. Just remember this point. Coming to the next slide, what I am showing you is Leaford. Is a integrated MCQ of ENT with ortho or general surgery. They can ask you Leaford fracture. What is a Leaford fracture? Leaford fractures, beta yaad rakhenge, they are classified on the basis of direction of fracture line. Just remember this line, direction of fracture line. They are based on the direction of fracture line, not direction of trauma. Like, what does it mean? If the fracture line is on the base of the maxillary sinus, it is Leaford 1. If it is at the level of orbit, I call it as leaf 4-3. And if it is along the nasolabial fold, we call it as leaf 4-2. Just remember with me, revise with me. Just on the floor of maxillary, it is leaf 4-1. At the level of orbit, it is leaf 4-3. And along the nasolabial fold, it will be leaf 4-2. I hope you're getting the point. Which are the 3 MCQs which should be on your tips on the leaf 4-1? Leaf 4-1 is known as low maxillary fracture. It is on the floor of the maxilla, so it is low maxillary fracture. I'm very happy everybody is responding in the chat box. That's great. You people have revised the notes properly. Low maxillary fracture. It is associated with a sign which is known as Guerin sign. Low maxillary fracture related with Guerin sign. When there is a trauma on the floor of maxillary, there is an injury to the palate. But we call it as floating palate. So these are 3 MCQs. 3 MCQs related with leaf 4-1, low maxillary fracture, Guerin sign, and floating palate. Am I understandable? Leaf 4-2, which is an important point, pyramidal fracture. Just remember, leaf 4-2 known as pyramidal fracture. And what is the important concept of leaf 4-3? In leaf 4-3, we have craniofacial. Cranium is separated from the face. Craniofacial disjunction. It is craniofacial disjunction. So leaf 4-1 low maxillary, leaf 4-2 is pyramidal, leaf 4-3 is craniofacial disjunction. What are the more other MCQs on this topic? They can ask you CSF rhinorrhea. So just remember, CSF rhinorrhea will be seen in which patient? CSF rhinorrhea will be seen in leaf 4-2 and leaf 4-3. But if I want to choose one, I will go for leaf 4-3. It is more in leaf 4-3. So these are the important MCQ beta. So one day, that's way we are learning ENT. You should try your best to revise in a fast mode. At this point of time, beta, we will not go in the depth of any topic. Agar koi topic samajh mein nahi aa raha, if you're not getting the topic, leave it. It is better to leave and jump to the next segment and just revise the keyword like leaf 4. If you give me opportunity in 1 minute, sir, leaf 1 is equal to low maxillary fracture, is equal to Guerin, is equal to floating palate. Leaf 2, sir, pyramidal fracture. What is leaf 3? Sir, craniofacial disjunction. CSF rhinorrhea in 2 patients, leaf 2 and leaf 3. If I want to choose one, go for leaf 3. I hope you're getting my point. So these are the leaf 4 classification basis of direction of trauma or direction of fracture line, On the basis of direction of trauma, if I want to classify on the basis of direction of trauma, it can be class 1, it can be class 2, it can be class 3 fracture. Now what is class 1 fracture? If the trauma is coming from below. If trauma is coming from below, it is class 1. If it is coming from front, it is class 2. And if it is lateral, multi-directional, it is class 3. So class 1 is from below, class 2 is from front, and class 3, that is your lateral side. It is coming from the lateral side. One MCQ on the fracture segment with a mandatory. Alphabet B is very near to C. So class 1 fracture known as Chevalet fracture. We call it as Chevalet fracture. Class 2, they are known as Jarjave fracture. Done. Class 3, multi-directional. We have no specific term for class 3. So class 1 is Chevalet. Class 2 is Jarjave fracture. Class 3 is multi-directional. Clear? Done. When the trauma is coming from below, we call it as if it causes a vertical fracture. If the trauma is coming from below, it will cause vertical fracture on the septum. And if trauma is coming from front, it will lead to horizontal fracture. Horizontal. So class 1 is Chevalet, class 2 is Jarjave, class 3 is multi-directional lateral fracture. I hope you're getting the concepts. Coming to the next slide, what I'm showing you. Yes, what I'm showing you. Any student. It is a double ring sign. Double ring sign. What is the importance of double ring sign in ENT? Yes, everybody should tell me. Double ring sign on a tissue paper. If you get a double ring sign on a tissue paper and double ring sign on HRC, CT. Yeah, let's see. How many students replied this one now? Double ring sign in ENT. If there is double ring sign in ENT on tissue paper, is your CSF rhinorrhea. Very nice. Excellent. Everybody is responding. And if it is on HRCT, can you tell me on HRCT? On HRCT, it will be on HRCT. It is. I'm waiting for the response in the chat box. Yes. Excellent. Dr. Naveen, the first student to reply. It is cochlear autosclerosis. It is cochlear autosclerosis. Excellent. Double ring sign on HRCT is here. Cochlear autosclerosis, HRCT of cochlea. They will be mentioning, they will be showing you the HRCT of cochlea. Clear. Don't get confused with the double density. Double density, one of the student is writing allergic fungal rhinosinusitis. Allergic fungal rhinosinusitis. I will be getting what is the keyword for allergic fungal rhinosinusitis? Two keyword. One will be peanut butter, and one is peanut butter like mucus, and one will be heterogeneous opacity. One will be peanut butter and one is heterogeneous opacity. Just remember this point. Clear? Very nice. Every student responding. This is CSF rhinorrhea. What is the important MCQ? What is the most common cause of CSF rhinorrhea? Surgical trauma. Then endoscopic trauma. What is the glucose concentration? Always remember, it is more than 30 milligram per deciliter. It is 30 milligram per, more than 30 milligram per deciliter. What is the investigation of choice? Beta -1 लेना ध्यान से सुनेंगे. Investigation of choice will be electrophoresis. Investigation of choice will be electrophoresis. What we see on electrophoresis, beta 2 transferrin. Last spell only focus on the keyword. Last spell only focus on the keyword beta 2 transferrin. But if examiner asks you the investigation of choice, radiological investigation of choice. If radiological investigation of choice for site of leakage, if examiner asks you for site of leakage, it is HRCT. Again, HRCT is there. Clear? What is the treatment? Treatment is wait and watch. Treatment is wait and watch. We give IV antibiotics. So treatment will be wait and watch with IV antibiotics. If patient is not responding for 3 weeks, like if patient is not responding 2 to 3 weeks, I'll be going for endoscopic trauma. Endoscopic trauma. So just remember, the most common cause is endoscopic trauma. And if the patient is not responding for 2 weeks, I'll be going for endoscopic repair. Just remember this point. So what endoscopy, what is the importance of endoscopy in CSF rhinorrhea? It is the cause, it is the treatment. It is the cause, it is the treatment. So if the patient is not responding for 2 weeks, I'll be going for endoscopic repair. I hope you're getting the concept. This is a big paradox. Absolutely yes. Coming to the next slide. What I'm showing you some black lesion on nose. Something to nose. It is your mucormycosis. Mucormycosis. The diagnosis will be mucormycosis. What is the important key word I want you people should remember? Better, there will be no pain, no bleeding. Everything is necrose. No pain, no bleeding. Am understandable? What is the drug of choice? Liposomal amphotericin B. If I see this type of lesion over the ear, it will be malignant otitis externa. Drug of choice will be third generation cephalosporin, and if it is on nose, it is mucormycosis. I hope everybody is comfortable with this slide. Mucormycosis, and one is here malignant otitis externa. Now I am showing you 2 slides. On one slide is one polyp, one big large polyp, what we call it as trilopolyp. This is antroconal polyp, single large. And if I get multiple bilateral polyps, that is ethmoid. No doubt in both the patient, whether it is ethmoid or it is antroconal, the treatment of choice will be FES. Agreed. But just remember this point, in antroconal polyp, there is no allergy factor. Because there is no allergy factor in antroconal, there is very less chance of reoccurrence. So reoccurrence is a property of, just remember, reoccurrence is a property of ethmoidal polyps. Clear? Reoccurrence is a property of ethmoidal polyps. Just remember this point. Coming to the next slide. Just one second. Yeah. Reoccurrence will be the feature of its model polyp. Treatment of choice in both the cases will be FESS because allergy is the main factor. Anti-allergic and steroid. Anti-allergic and steroid. They are given in ith model polyps. We are not using in antroconal. Polyp. Done. Coming to the next one. This is which benign tumor? There's a white mass. Now let us do mastery of this topic, but this MCQ have to be there. So let us play with this image now. There's a one benign tumor, white mass on antepart of nose, antepart of septum. Yes, it will be papilloma. Agreed? Papilloma. If it would be reddish. If it is reddish, I will be going for two diagnosis. If that red mass is coming, listen carefully. If the reddish mass is coming from septum, it will be capillary hemangioma. And if it is coming from inferior turbinate, if it is coming from septum, capillary hemangioma. If it is coming from inferior turbinate, that is on the lateral side, that is your cavernous hemangioma. Capillary hemangioma, cavernous hemangioma. If a same white mass is coming from lateral wall, if some white mass is coming from lateral wall, I call it as inverted papilloma. So all these students listening to me, white mass on septum is papilloma. On lateral wall is inverted papilloma. Very important topic, also known as Ringer's tumor. Inverted papilloma. Why it is important? It is pre-malignant. Inverted papilloma is pre-malignant. And what your NEET people will ask you? NEET people will ask you to differentiate inverted papilloma from squamous cell carcinoma. Why? Because inverted papilloma and squamous cell carcinoma, both they are coming from lateral wall. So beta, आप लोग कैसे differentiate करोगे? If something is coming from lateral wall, the golden rule. If something is coming from lateral wall, very good, Dr. Abhishek, excellent. What I will be looking for? I will look for maxillary sinus. Just remember the golden rule. I will be looking for maxillary sinus. If maxillary sinus is damaged, if it is damaged, it means it is squamous cell carcinoma. If it is intact, I'll be going for inverted papilloma. I hope you're getting the one. The other method will be obviously your histopathic examination. You can differentiate inverted papilloma from squamous cell carcinoma. Clear? Always remember, squamous cell carcinoma age distribution is more than 60 years. While inverted papilloma, the age distribution is 40 to 60 years. 40 to 60 years. This way, we have to differentiate one tumor from the other. Clear? What is the treatment of choice? Is lateral rhinotomy. I have to go for surgical excision. And which incision we use? We give an incision on the lateral wall of nose, which is known as lateral rhinotomy incision. Lateral rhinotomy. Anybody who can write the other name of lateral rhinotomy? If this is my nose, I'm giving the incision along the lateral wall of the nose. That is known as Moore's incision. What is the other name of lateral rhinotomy incision? We use a word, Moore's incision. Beta, Dr. Kunal, Weber-Ferguson incision is for maxillary sinus. We are using for maxillary sinus. Okay, so these are the important points related with your nasal cavity. One important formula you should remember: the most common, if the examiner asks you about paranasal sinus, most common benign tumor, the most common benign tumor is osteoma. Just remember this part. And this osteoma is in frontal sinus. Osteoma is in the frontal sinus, is the most common benign tumor. If examiner asks you most common malignancy, it is your squamous cell carcinoma. Which patient? Maxillary sinus. And squamous cell carcinoma, maxillary sinus tumor, they are common in nickel industry. So beta, 1 week before your examination, everything should be converted into formula. At this point of time, no bulky notes, beta, not at all. I should have my ENT in 15 pages, the formulas which we have to revise again and again. And what is the second most common malignancy? Is adenocell carcinoma, which is common in ethmoid. Which patient? Wood industry. So these are the important points. adeno in wood industry, and squamous cell carcinoma in nickel industry. So these are the important topics related with your nasal cavity. Coming, I hope everybody comfortable with all these one-liner MCQs beta. Just try to appreciate we are running behind 2 MCQs. Out of 10, 2 MCQs will be coming from your nasal cavity. And we have studied so many, more than 100 important concepts in the last half an hour. So out of which they will pick any 2. I hope you are getting the message. Okay, beta, and this is a high time when we'll be reading superficially. Whatever we have read, revise in a very fast mode. Don't stuck at one point. Don't stuck at one point, beta. Am I understandable? Are you getting this point? If we want to crack, and take my word, work 24 into 7, beta. Abhi humne raat ko, take my word, beta, no need of going in a very conceptual slow manner at this point. This is the time, like last 1 over is left, 6 balls are there, and we have to hit on each ball. On each day we have to give our best performance. Am I understanding? No negative thought, nothing, just try to give your best. I always say try to give your best performance. This is the motive of next few days, beta. I'm understandable. And all these sessions, they will give you momentum. Like after attending this session, you will feel, okay, ENT, at least we know most of the important topics of ENT, will manage to attempt all the important MCQ. If you have not read any topic till now, any topic of any segment, and like say you have not read the classification of maxillary sinus, don't touch at this point of time, beta. Just whatever you have studied till now should be revised again. This is the only one thing which I want to convey on this platform, beta. हम इस टाइम पे कुछ नया नहीं पढ़ेंगे बेटा, कुछ भी नया नहीं पढ़ना. अगर आपका, if any of your friend is telling that these classification are important and you have not studied those classification, forget beta. I will not do any single thing which will spoil my confidence, before the examination, beta. I will work whatever we have studied, we will try to play the game with that stuff, but revise in multiple time. You should try to revise, and last 1 day just relax and go with a confidence. And one more strong message on this platform, beta, try to reach your venue on time, beta. Try to reach venue on time. Time management is one of the most important factor. Go there with peaceful mind. Don't discuss anything before the examination. Just go with a cool mind. Play like MS Dhoni, cool mind. And even if you don't know the topic, agar topic nahi bhi aata, to beta 4 choices are with you. Try to apply the common sense. Try to extract the best possible answer, and try to attempt as many as possible. Be aggressive player if you want a good rank. Coming to the next slide, the first slide of larynx. Why is the first topic of larynx? No. This is the first MCQ which examiner always give you in topic of larynx. Papillomatosis is associated with papillomatosis. One of the student is writing, is scared of pharma. No issue, but if you're not now, no scare, no fear should be there. Just focus on the revision part. So papillomatosis, human papilloma virus, number 11 and 6 याद रखेंगे बेटा. Pharynx में 16 होता है, larynx में 11 और 6 होता है. Clear? That very simple. Now, clear. One of the students is writing, I am only revising DVT. बेटा just revise it multiple times. If you ask me, अगर मैं आपकी चेयर पे होता at this point of time, only DVT with PYQ, that is more than sufficient. More than baki, so there is no upper limit. I can teach you ENT for 7 days, but now is time pe DVT and PYQ, that's it. More than sufficient for improving your rank at this point of time. Coming back, papillomatosis, juvenile papillomatosis, senile papillomatosis. Juvenile is multiple. They are multiple. They resolve spontaneously. They reoccur spontaneously. As for senile, as for single, they never resolve, never reoccur. What is the treatment? Which laser we use? CO2. C for CO2, C for cidofovir. We use a drug which is for this papillomatosis. We are using cidofovir. Clear? That very simple. Coming to the next one, it is a pre-malignant. Just remember, it is pre-malignant. C for CO2, drug of choice, cidofovir. It reduces the chance of reoccurrence. ये भी समझ में आता है. Coming to the next slide, what is the importance of this slide? Yeah, this is a very important slide for your NEET examination. Why? Because this disease commonly seen in our country, so tuberculosis. So I am talking about TB larynx. So in TB larynx, they will be asking you mouse bitten appearance of the vocal cord. So this is a typical finding of mouse bitten appearance. Which commissure is involved? Always remember it is posterior commissure. It is posterior commissure. I'm giving you few MCQs of TB which I'm expecting this year. They will ask you most common symptom. If examiner asks you most common symptom, beta, it is weakness of voice. Weakness of voice. And if examiner asks you most common sign will be loss of adduction. Loss of adduction. Loss of adduction. That most common site is posterior commissure. Most common symptom is weakness of voice, loss of adduction. Earliest sign, if examiner asks you earliest sign will be hyperemia of the posterior commissure. Hyperemia of the posterior commissure. Just remember these points. Okay? Treatment will be ATT. Clear? Dr. Javed is asking, it is painless or painful. Just remember, beta, TB nose, TB ear. If the examiner asks you about TB ear, it is painless. This is painful. This is painful. Clear? Clear? Coming to the next point, thyroplasty is very important. We have 4 types of thyroplasty. Ishika classification should be on your tips. Type 1 is medialization. If you bring the vocal cord near to each other. Type 2 will be lateralization. Type 1 is done for superior laryngeal nerve palsy. Type 1 is done for superior laryngeal nerve palsy. Clear? Very nice. One of the students is writing extra points in the chat box. Excellent. Excellent. So type 1 is superior laryngeal nerve palsy. Type 2 is done for recurrent laryngeal nerve palsy. Type 1 superior laryngeal nerve palsy. Type 2 is your lateralization, recurrent laryngeal nerve palsy. Type 3 is done to reduce the pitch. Whenever I want to reduce the pitch, like puberphonia. In puberphonia, the child is having high pitch. So I want to reduce the pitch if patient is not responding to psychotherapy. So just remember, it is your puberphonia treatment of choice is psychotherapy. But if the patient is not responding to psychotherapy, I can go for type 3 thyroplasty. Type 4 thyroplasty is done to increase the pitch. Increase the pitch. Just remember, it is done to increase the pitch. Which patient? I will increase the pitch. Androphonia. Very nice. Everybody is writing in the chat box. It is androphonia. So these thyroplasty very important for upcoming examination. Then what I'm showing you, what is this slide? The both vocal cord, there's some bulge on the mucosa. There on examination, there's some edema beneath the mucosa. Edema beneath the mucosa, we call it as Rinke's edema. Rinke's edema. Just remember. So what is the importance of this slide? If they show you any fluid in the vocal cord, I will try my best to explain this topic in a nice way, because one MCQ is expected. This is my right vocal cord, left vocal cord. If they show you edema on the whole vocal cord, this is Rinke's edema. If they show you something at the junction of 1/3, 2/3, and only on one vocal cord, it will be polyp. And if they show you on both the vocal cord only at the junction of 1/3, 2/3, it is nodule. Beta samajhna is baat ko. If it is bilateral, it will be nodule. If it is unilateral, it will be polyp. Am I understandable? If it is bilateral, it will be nodule. If it is unilateral, it will be polyp. If there is a diffuse swelling on the whole vocal cord, is your Rinke's edema. समझ में आ रहा है? हाँ जी, बिल्कुल. And if they show you big swelling on the posterior commissure, anyone who can tell me if they show you something big swelling on the posterior commissure, what is this one? Any student who can reply this type of appearance? If they show you something big on the posterior commissure, we call it as intubation granuloma. So this is known as intubation granuloma. I hope you will never forget now. Very good, Dr. Abdul. Excellent. It will be intubation granuloma. This slide will help you to crack multiple MCQs. Just try to learn better. If it is on the whole vocal cord, diffuse swelling, it is Rinke's edema. If it is on the anterior 1/3, posterior 2/3, it's a polyp or nodule. If it is unilateral, polyp. What is the beauty of polyp? We have to operate. What is the beauty of polyp? We have to do surgery. What is the beauty of nodule? Wait and watch. I always say, and for nodule, and for no surgery, wait and watch. Just remember, Rinke's edema. What is the treatment of Rinke's edema? We do microlaryngeal stripping. This word should be there in the MCQ. Microlaryngeal stripping is done for Rinke's edema. Now at this platform, I'm teaching you microlaryngeal stripping is done for two patients in ENT. One is Rinke's edema, one is keratosis. So better just remember 2 points: Rinke's edema or keratosis. Microlaryngeal stripping will be done. Intubation granuloma will be again conservative management. We'll be going for wait and watch. Done. So this way we differentiate. Very good, beta. Keratosis means leukoplakia. Excellent. Everybody is responding in the chat box, beta. The speed at which the chat box is moving, it proves that you people have revised all the DAMS class notes very nicely. Coming to the next slide. After learning this intubation granuloma, what I am showing you some mismatch. Can you appreciate? There's some asymmetry between right and left vocal cord. This is a topic dedicated to vocal cord paralysis. So beta, हमने क्या याद रखना है 5 days before the examination? Vocal cord paralysis. I will not go in the depth of this topic. Little bit difficult topic, but in the last spell we will remember, sir, in whether it is unilateral recurrent nerve palsy or unilateral superior laryngeal nerve palsy. We will go for wait and watch. Why you will go for wait and watch? Sir, only one symptom is there, hoarseness. So beta, every student sitting with me, revise in unilateral recurrent or unilateral superior, whether it is unilateral recurrent or it is unilateral superior, the symptom is only one, hoarseness. Therefore we go for conservative management. If it is bilateral recurrent nerve palsy, one symptom is there, dyspnea. This is a expected MCQ. After any head and neck surgery, patient land up with severe dyspnea. Which important complication? It is bilateral recurrent nerve palsy, and if it is bilateral superior laryngeal nerve palsy, patient will be having complete loss of voice with aspiration with complete loss of voice, aphonia. Clear? So bilateral recurrent nerve palsy and bilateral superior laryngeal nerve palsy, we have to go for surgical intervention. Like I taught you, the method of lateralization, all the method of lateralization like type 1 thyroplasty will be done in superior laryngeal nerve palsy. You have to do cordectomies, or we can go for arachnodectomy. This is bilateral. And if bilateral superior, if it is bilateral recurrent, we have to do type 2 thyroplasty, or we have to inject something in the vocal cord, like injection of Teflon, injection of gel form. This we have to inject. So just try to learn one thing. If any of the option, like examiners say, bilateral recurrent nerve palsy, which of the following is not a procedure, which or the following is not a treatment. So just remember, beta, if it is recurrent nerve palsy, we add something like injection of Teflon, injection of gel form. By in superior laryngeal nerve palsy, we remove that structure. That is, we have to lateralize, common sense. So it is cordectomy or arachnodectomy. Done. So these are the important points related with your vocal cord paralysis. Coming on the next one, very important point, that is your thumb sign. I am showing you this thumb sign, a feature of epiglottitis. This is a feature of epiglottitis. Many students asking this controversial MCQ, which bacteria? So it is streptococci. Drug of choice will be IV antibiotics, but just remember, we have to admit the child in ICU. We have to take care of the airway, because this is a very toxic patient. Toxic means collapse. He can collapse at any point of time because airway is compromised. If examiners show you this type of slide, this is your stipple sign. Stipple sign is a feature of croup. C for croup, C for chronic, C for conservative management. I will be going for oxygen bronchodilators, but not IV antibiotics. Why? Because it is caused by para-influenza virus. Just remember this part. Clear? So this important slide for ENT as well as PEDS. Any topic where more than one subject can be covered will be important MCQ. Am I understandable? Like early foot fractures, very important, crucial. Tracheostomy, very important topic. Epiglottitis, croup, they are very important topic. Clear? Coming to the next slide. Before going into the ear segment, I want to teach you some more important points of larynx. vocal cord paralysis, what are the important topics? Like 5 days before the examination, which topic should be untouched? हम कोई ऐसा topic जो हमने नहीं पढ़ा हुआ, if that topic is among these 5, please kindly revise the key point of those topics. One is your papillomatosis, expected MCQ. If you ask me which are the 5 important expected MCQs from which the examiner will make the question, one is papillomatosis, very important beta. Clear? Rule of vocal cord paralysis, where you will go for type 1, type 2, type, all these points should be on your tips. Vocal cord paralysis, epiglottitis against croup, one of the important topic. Then one is CA larynx, never miss this topic beta. CA larynx, never ever miss this topic. One MCQ expected from CA larynx. Then the examiner can ask you congenital dyspnea, because this is an area where examiner will make an integrated question of ENT with ear pediatrics. Congenital dyspnea, just remember, supraglottis is your laryngomalacia. In laryngomalacia, it is omega-shaped epiglottis, which will be the keyword prone position. The child is very comfortable in prone position. Examiner can ask you about glottic. In glottic beta, there is a congenital webs, just remember. And subglottic area, we have either stenosis, I will have stenosis, subglottic stenosis, or it will be hemangiomas. Hemangiomas will be there. So these are the 2 important points related with subglottic segment. Okay. Coming on CA larynx, this is one of the important segment. So if you ask me to just touch the keywords of this topic, most common predisposing factor is smoking. Most common type is squamous cell carcinoma. Just remember this point. Glottic tumors, the treatment of choice is equal to radiotherapy. In the other tumors, the treatment of choice is such. But what is a golden rule? What is the golden rule of ENT, CA larynx? In all tumors, just remember, in all tumors, the first line of treatment will be your radiotherapy. First line of treatment will be your radiotherapy. Just remember this one. First line of treatment will be your radiotherapy, whether it is CA larynx, glottic tumor, supraglottic tumor. The first line of treatment will be radiotherapy. Then, now, if the patient come in T1 or T2, just remember T1, T2, we use single modality. We will be using any patient of T1, T2, we will be using the first line of treatment as radiotherapy only. But if examiner asks you treatment of choice, so then you have to decide how. If it is glottic tumor, I'll be going for radiotherapy. And if there is any other tumor, we go for partial laryngectomy. Nowadays, we are not doing these surgeries. Why? It have many complications. Just remember this point. In this, they can ask you HPL, horizontal partial laryngectomy. It is done for supraglottic tumors. So examiner can ask you in partial HPL, which investigation is mandatory. So just remember, pulmonary function tests are important. If examiner give you T3, T4 की treatment क्या होगी बेटा? T3, T4 treatment will be total laryngectomy. We will remove the whole larynx we will go for radiotherapy. Total laryngectomy followed by radiotherapy. If the patient deny, अगर patient मना करता है, if the patient deny, then only I will be going for concurrent chemoradiation. I will be going for concurrent chemoradiation. I will be going for concurrent chemoradiation. Very simple. Which radiotherapy, chemotherapy we are using? We are using cisplatin and 5-fluorouracil. We are using cisplatin or 5-fluorouracil. Same chemotherapy is used in which other tumor of ENT we are using? We are using in nasopharyngeal carcinoma. We are using same. Very good, excellent. Terminal stage. If the patient come in the last stage, we go for palliative management. If the patient come in the last stage, I will be going for palliative management. These are the important points which should be on your tips. Then they can ask you after surgery, after total laryngectomy, what is the golden rule? We do vocal rehabilitation. Vocal rehabilitation. What is the oldest method of vocal rehabilitation? Esophageal voice. How many words we can speak with the help of esophageal air? That is 6 to 8 words. 6 to 8 words. Then the next method is electrolarynx. Electrolarynx. Again, one of the important method. Esophageal voice is a failure, is not a successful method. And the latest method we people are using, tracheoesophageal prosthesis. We are having tracheoesophageal prosthesis, which is of 3 types. One is oldest one, that is Blom-Singer. One is by the name of Provox, Provox, and one is Pangy voice button. If they show you something button like structure, it is Pangy voice button. Just remember this point. These are 3 type of tracheoesophageal prosthesis. One MCQ I'm expecting in NEET, that is your polite yawning. They can ask you what is polite yawning. Polite yawning, naam iska polite hai, is not a polite yawning. But what do you mean by polite? You have to yawn with closed mouth. So when you close your mouth and you yawn, post laryngectomy patient, we use polite yawning. Anybody who can tell me in the chat box why we use polite yawning? We use, what is the use of polite yawning? It is for olfactory regeneration. It helps in olfactory refunctioning. So polite yawning is used for olfactory refunctioning. So these are the important keywords related with CA larynx. Clear? Done. Coming on the next slide, concentrate on the board. Coming on the next slide, yes, what I am showing you, I am showing you traumatic perforation. If the examiner show you some blood, some history of trauma, if there is some trauma entering into the otology segment, maximum MCQ will be coming from ear only. If any history of trauma, any blood clot seen, that is your traumatic perforation. What is the important rule of traumatic perforation? Just remember, we have to go for wait and watch. We have to keep the ear dry. Examiner can ask you this one, ear dry. Just keep the ear dry. The perforation will heal of its own within 3 months. 3 months. 3 months is the right answer of grommet insertion. 3 months is the right answer for your traumatic perforation. 3 months is the right answer for chronic sinusitis. Just remember this one. Coming to the next one, what is this slide? There will be clinical history. They will give you a clinical history. Just consider it on the board, clinical history, in which they will be using the word osteocyte. They will be using the word bone. They will be using the word periosteum. So beta yaad rakhenge, any MCQ of paranasal sinus, if they use the word periosteum, they use the word osteocyte, they use the word bone, so they are talking about osteomas. If they talk about in the external auditory canal, it is osteoma, also known as which ear? We call it as surfer ear. Surfer ear. It is commonly in those who are having history of ear swimming, cycling, or using speedy water boats. So we call it a surfer ear, osteoma formation. Treatment of choice will be surgical excision. Treatment of choice will be surgical excision. Am I understandable? Examiner can show you this slide, how we'll differentiate it from the cholestoma. So just remember, in osteoma, there will be no evidence of necrosis. In osteoma, necrosis, or no evidence of necrosis will be there. Coming to the next slide, can you make a spot diagnosis? There is a reddish mass. The examiner is giving the key word. There is red mass behind tympanic membrane. There is a reddish mass behind tympanic membrane. Examiner is using a word pulsatile. Pulsatile. So I'm talking about which? I'm talking about glomus tumor. I'm talking about glomus tumor. Reddish mass behind tympanic membrane. Just remember, reddish mass in subglottic area. Subglottic, that is hemangioma, and reddish mass behind tympanic membrane is your glomus tumor. What are the important points? What is the most common site of glomus tumor? Just remember, most common site of glomus tumor will be your tip of your finger. Your nail bed or tip of your finger is the most common site. Just remember, if the tumor is coming from floor, that is glomus jugular. If the tumor is coming from the floor, glomus jugular, so just remember important signs: rising sun sign, rising sun sign. The tumor is growing like a sun, we call it as rising sun sign. We can get brown sign. What is brown sign? Brown sign is blanching of the tumor, blanching of the tumor on pressing the tympanic membrane, tympanic membrane. They can ask you what is aquinosine. Aquinosine is blanching of the tumor by pressing the neck vessel. If you press the neck vessel, the blanching is there, that is your aquinosine. They can ask you which artery we embolize in glomus tumor. Just remember, we embolize ascending pharyngeal artery. We embolize ascending pharyngeal artery. Clear? So these are the important points related with the glomus tumor. Expecting one MCQ in the glomus tumor, so please revise it in a nice way. Now, what I am showing you the next slide, if this question is repeated, an examiner is mentioning the word hearing loss. What I am showing you on this slide, I am showing you blebs. I am showing you some balloon-like swellings, blebs. And if along with the blebs, hearing loss is there, if hearing loss is there, that is your serous otitis media, that is your serous otitis media. And if examiner mentioned the word severe pain, we call it as meningitis bullosa, meningitis bullosa. One of the student is asking me what is aquinosine. Just remember, aquinosine is blanching again, but in brown sign, blanching was because of tympanic membrane. You exert pressure over the tympanic membrane, but in case of aquino, the blanching is by pressing the neck vessel, neck vessel. Clear? So hearing loss mentioned, one MCQ in serous otitis media expected with. Just remember what is the mindset of the examiner in serous otitis media. In serous otitis media, they will ask you, is there any role of adenoidectomy? So examiner will give you a typical history of adenoid faces. Then he will be giving the history of hearing loss. He will give you this type of image, high arch palate. I will be going for serous otitis media. Treatment will be myringotomy with grommet insertion. So treatment with myringotomy, grommet insertion with adenoidectomy. If the patient is not responding, I'll be going for adenoidectomy. Clear? Coming to this slide, this is your grommet. Now just listen, every student, carefully. This MCQ I'm expecting. The grommet. Grommet is the treatment, for serous otitis media. Serous otitis media. That. Now, what is this I'm showing you? Can you tell me what is this one? What is this? Yes, any student? This is your sclerotic patch. So what can be the complication of grommet? So just remember this. In case of you are using this grommet, we have a risk of sclerotic patch. We call it as tympanosclerosis. If they show you this slide, tympanosclerosis, it can be, what will be the symptom? Will be conductive deafness. And what will be the first line of treatment if the patient is having hearing loss due to patch, tympanosclerotic patch? The hearing aid is the first line of treatment. Just remember, why I'm wasting my time? Sometimes the examiner give you a choice. This was the MCQ, very old MCQ of AIIMS examination. The hearing aid is one of the cause of tympanosclerosis. False statement. It is false. Hearing aid is one of the treatment option for tympanosclerosis. I hope you're getting the concept clear. So if you do any procedure on the tympanic membrane, it can land up with a sclerotic patch. So grommet can be one of the cause, but treatment will be hearing aid. Kindly thumbs up if you get this concept in the chat box. If the examiner asks you the cause will be grommet or any other otologic procedure. If examiner asks you the first line of treatment, it will be hearing aid. Don't mix these words. They will combine and they will confuse you. Which of the following is a false statement? Done. Now I am showing you a cartwheel appearance of tympanic membrane. If you see a cartwheel appearance of the tympanic membrane, this is going in feature of ASOM, in going of favor of ASOM, acute suppurative otitis media. How we will differentiate? Very good, very nice. Before asking the question, Dr. Kunal is replying in the chat box. This is what is the need of R. Examiner आपसे पूछे उससे पहले you should hit कि हाँ, he will ask you this point. Am I understandable? So I will take from this Dr. Kunal's message. I will give you one strong message, beta. Read the option first. If you read the option first, sometime you can hit the MCQ directly focusing on the keywords. Like you see, glomus tumor, your eyes will be searching for pulsatile. Pulsatile word written. Don't waste your time in reading the rest of the MCQ, beta. Better to jump on the next question. I hope you are getting my question. Otoscopes mentioned. Your eyes will be searching for. Your eyes will be searching for Carhart notch. Your eyes will be searching for a young female with a history of hearing loss. You will be right. Your eyes will be concentrating on these keywords. Clear? So if Carhart notch mentioned, Schwartz sign mentioned, you will directly hit on auto. I will not waste my time on reading the audiometry finding of the patient. I hope you are getting my point. So ASOM, lighthouse, cartwheel appearance will be stage of pre-suppuration. Lighthouse sign will be stage of suppuration. These are two MCQs. You should be confident. Again, revise with me. Cartwheel appearance, it is stage of pre-suppuration, and lighthouse sign will be in stage of suppuration. Clear? Treatment, again maryngotomy, but it will be a circumferential, it will be a circumferential incision in a posterior inferior, and sinusoidal media is anterior inferior. So very nice, very nice. Everybody is responding. Coming to the next slide. What is the important slide? This is my cochlea, clearly visible to me. Next, I will magnify the slide. This is my middle ear visible. Then examiner is highlighting one important area which is between malleus से याद आया, how to differentiate malleus from incus? So head of malleus. So if the examiner show you something convex, it is head of the malleus. This is malleus. If examiner show you something concave, it is incus, fossa of incus, fossa incidus. Clear? नहीं बेटा नहीं, Dr. Kunal, नहीं. This answer, and now I feel he have deleted. No, it is not superior semicircular canal dehiscence syndrome. This is one space. This is a space, beta, between the space between malleus space between malleus and tympanic membrane. This is my external auditory canal. This is my external auditory canal, and this is my malleus visible to me. This is par flaccida visible to me. Can you tell me what I am showing you? I am showing you the most common site for cholestroma formation. One of the student, बेटा कुणाल, आपने you have updated superior semicircular canal dehiscence syndrome. बेटा वो तो यहाँ होगा ना, यहाँ पे कॉक्लिया के ऊपर, यहाँ पे if they show you something dehiscence, some fistula in the upper part of inner ear, then I will go for superior semicircular canal dehiscence syndrome. And what is the important finding of superior semicircular canal dehiscence syndrome? Will be conductive deafness. बेटा याद रखना, कुछ याद रहना रहे. Conductive deafness with CNS symptom is superior semicircular canal dehiscence syndrome. Treatment is like CSF rhinorrhea. Wait and watch. Not responding, go for surgical repair. This is prosec space. Then this slide is very important. Examiner will ask you the sinus tympani. So my aim of showing this slide, this is for teaching purpose. I am taking this is your first metro station, that is processus cochleaformis. So on the medial wall, which are the three MCQs, which are the three metro station waiting for you? One is posterior ear, medial. I'm talking about medial wall. Processus cochleaformis. What is the importance of processus cochleaformis? Is the entry point of facial is attachment of tensor tympani. What is just behind processus cochleaformis? Oval window. And what is behind oval window? We have sinus tympani. What is the importance of sinus tympani? It is the most common site for residual disease. It is the most common site for reoccurrence, residual or reoccurrence. Then this is my pyramid. What is a pyramid? Attachment of stapedius muscle. Now this is my facial going. So facial is medial, then it is going in the mastoid, and from mastoid my cauda tympani is coming. So if examiner asks you which are the important metro station on the medial wall, so on the medial wall the metro stations are three important stations. One is processus cochleaformis, one is oval window, one is sinus tympani. Clear? And behind is your posterior wall, that is your facial, pyramid, cauda tympani. One of the students is asking, I have revised DVT, PYQ, should I attend this session? Definitely, beta, it will help you. My words will help in the examination. I am confident. In the evening of 5th of March, you will be giving me the message, sir, हमें ऐसा लग रहा था, you were standing with us and you are telling me the right answer. So beta, जितनी बार सुनोगे it will help in the examination hall. Clear? I promise you that this feel you will get in the examination hall. Now what I'm showing you two slides. Slide number 1, slide number 2. What is slide number 1? Slide number 1, it is here in the lower part matlab it is a tubotympanic ear. It is tubotympanic ear disease in the lower part. If you see the disease in the upper part, ye kya beta? This is aticoantral. This is aticoantral. Just remember beta, what is the treatment of slide number 1? If examiner asks you the slide number 1, treatment for slide number 1, it is here tympanoplasty with OCR, ossicular chain reconstruction. So treatment for tubotympanic is OCR. OCR is of two types. One is PORP, partial ossicular replacement prosthesis. One is TORP, total ossicular replacement prosthesis. If the examiner asks you about partial, that is done for type 3 tympanoplasty, and total की बात करेंगे तो बेटा हम type 4 को टिक कर देंगे. What is the treatment of aticoantral ear? Sir, modified radical mastectomy. And what is modified radical mastectomy? Sir, is a type of canal wall down procedure. So which mastectomy commonly done? Which mastectomy is commonly done in ear? Unsafe ear is your canal wall down. Canal wall down. Which canal wall down? We are doing modified radical. If examiner asks about radical, in which we block the ET tube and we remove everything, we block the ET tube, we remove everything, we are going for radical mastectomy. Just remember, radical is done for malignancy part. Malignancy part. Clear? Coming to the next slide. Yes, what I'm showing you. This, what is the importance of this slide? The importance of this slide is the most common extracranial. This is the most common extracranial complication. This is the most common overall complication. Which complication I'm talking about? I'm talking about mastocytitis. I'm talking about mastocytitis. Clear? One of the students is asking me aticotomy. So just remember the word itself is telling you beta. Aticotomy. We are opening the epitympanum. So we are having like radical mastectomy, modified radical aticotomy. These are canal where my focus will be in the upper 1/3 of middle ear. I'm mainly concerned about the upper 1/3. We are using this word aticotomy. Clear? This is not battle sign beta. This is not battle sign. This is no ecchymosis below the pinna. There is no history of any fracture, trauma. We are learning the topic of CSM. So examiner will be giving the typical presentation of ear discharge. So one of the student who is writing the word battle sign, this is not battle sign. This is like, you can say, ironing of the mastoid, earlier sign. So mastocytitis is most common complication. Examiner can ask you most common symptom. If examiner asks you most common symptom, it is ear discharge, persistent ear discharge. If examiner asks you most common sign, it is tenderness. If examiner asks you the earliest sign, it is your ironing of the mastoid. And if examiner asks you the hallmark sign, yes, anyone? Hallmark sign is your sagging of the canal. The posterior wall will be sagging of the canal. All these are points related with mastocytitis. Then they can ask you the important MCQs on related with the muscles of the muscle involved as a complication of mastocytitis. So if there is an abscess around sternocleidomastoid, we call it as Bizzard. Ye yaad hona chahiye beta. Bizzard abscess. If there is an abscess along digastric muscle, we call it as Sertali's abscess. If there is a behind pinna, we call it as post-auricular, and post-auricular is the most common abscess. Just remember beta, every student listen again. Most common abscess in unsafe ear in your CSM is your post-auricular abscess. Most common is post-auricular abscess. Okay. Then examiner can ask you labyrinthitis is one of the important complication. Which canal is involved? Lateral semicircular canal is involved. Which part of the facial nerve is commonly involved? Tympanic part. Is commonly involved. If my Peter's bone is involved, I'll be having one triad. What is the name of that triad? We call it as Grednigo triad. Clear? So in ENT, just remember we are having two triad. One is Trotter's triad, one is Gradnigo. Trotter's triad will be 5th and 10th, but in Gradnigo it is 5th and 6th. 5th and 10th will be Trotter's triad. What is Trotter's triad? Trotter's triad related with your nasopharyngeal carcinoma. Trotter's method is epistaxis. Pinch the nose, spit out the blood. Epistaxis. Again, one of the important topics. Phenopalatin artery is the artery of epistaxis. Remember this point. Clear? So again, revise with me. 5th and 6th is Gradnigo. 5th and 10 is Trotter. Then examiner can show you two slides. Either examiner will show you this one. If examiner show you this, this is your temporal lobe abscess. And if examiner show you number 2, that is some empty delta sign on contrast enhanced CT. Contrast enhanced CT, that is your lateral sinus thrombosis. Integrated question of ENT radiology, high probability can be there. So examiner showing you this slide will be your temporal lobe abscess. This is your lateral sinus thrombophlebitis. All the important 5 keywords of lateral sinus thrombophlebitis should be on your tips. What is the 5 important sign of lateral? One is empty delta. Everybody know empty delta sign. Then one important point, there will be edema over the mastoid. When there is a edema over the mastoid, we call it as Grisinger sign. If there is a edema over the retinal vein, we use a word Croback sign. If you press the jugular and there is no increase in ICT, pressing the jugular, no increase in ICT, we call it as Tobbe-Ayer sign. And this patient have a very spiky fever, which is known as hectic fever. Spiky fever is there. These are the 5 important findings related with lateral sinus thrombosis. Done. Coming on the next slide, if the examiner show you a reddish hue on the tympanic membrane, pregnant female, reddish hue or the tympanic membrane, this is a typical finding of Schwartz sign. Just remember, it is Schwartz sign. It is a feature of autosclerosis. What is the importance of Schwartz sign? It is a contraindication of surgery. It is a contraindication of surgery. Schwartz sign, contraindication of surgery. Done. So it indicates the early stage. So if Schwartz sign is there, I will not operate. I will be going for sodium fluoride. So what is the drug of choice? Drug of choice of autosclerosis, sodium fluoride. What is the treatment? Is your stepidotomy, which is better than stapedectomy. Stepidotomy, which is better than stapedectomy. Done. So autosclerosis, which is an important finding, Carhart notch. And worth remembering point, you people should tell me, Carhart notch is seen in air conduction, bone conduction. Just remember, it is seen in bone conduction. Carhart notch, feature of bone conduction. Then after stapes surgery, the worth remembering point, the Carhart notch will disappear. The tympanogram will be AD graph. What is a hallmark feature of autosclerosis is AS. But if after surgery you will be having AD graph, these are the points on which they can format MCQs. Let us learn few important tympanogram. What is the importance of tympanometry? The golden rule, impedance audiometry. Impedance audiometry is the investigation of choice for conductive deafness. So impedance audiometry is the investigation of choice for conductive deafness. If examiners show you this step, one MCQ on tympanometry expected, so please let us revise nicely. This is a normal graph. So whenever the ear conduction will be normal, this graph will be seen. This type of graph will be seen when there is a hypomobile tympanic membrane. If there is a hypomobile tympanic membrane, what is the example of hypomobile tympanic membrane? Autosclerosis, autofibrosis, tympanosclerosis, tympanofibrosis. If this type of graph is there, we call it as AS. If examiners show you this type of graph, this is a feature of hypermobile. Hypermobile tympanic membrane is seen in ossicular damage. It is seen in ossicular damage. If the tympanic membrane is perforated, if tympanic membrane is perforated, we call it as B tympanogram. Or also known as fluid in the middle ear, we call flat tympanogram. So beta yaad rakhenge, flat tympanogram and perforated tympanic membrane. Flat is equal to fluid. Flat tympanogram and B tympanogram, they are identical. They are identical. They will be this type of graph will be there. And if they show you one graph which is shifted on the x-axis, that is normal graph, the peak is at 0, delta p is 0, this is normal graph. And if tympanic membrane is slightly, this graph is slightly shifted on the x-axis, maybe on the right side, maybe left side, we call it as ET tube dysfunction. ET tube dysfunction. Please revise all these types of tympanogram. Beta, one MCQ expected on tympanometry. Okay. Investigation of choice for conductive deafness, and on this platform we can learn investigation of choice for sensory deafness. What will be the investigation of choice for sensory deafness? Will be electrocochleography. For neural deafness, it will be brainstem evoke response audiometry, or it can be cortical evoke response audiometry. Bara or Sera. Sera is for the higher centers. Bara is up to here inferior colliculus. Then this is a typical double ring sign. Can you appreciate? This is cochlear autosclerosis. So in cochlear autosclerosis, you will be getting two rims. One rim will be of cochlea, second rim will be sclerotic foci. Which pure tone audiogram will be seen in cochlear autosclerosis? We get cookie bite audiogram. There is one rare finding of cookie bite audiogram. Cookie bite audiogram. Coming to the next slide. Any student who can tell me, can you spot a diagnosis? There is a long history, 5 to 6 lines of the history with this graph is given. If this graph is given, I'll be getting the message. It's a graph is moving up, up, up. I will call it as rising curve, not rising sun. This is rising curve. Rising sun was in glomus tumor. Rising curve is in Meniere's disease. What is the feature? It is low frequency hearing loss. So low frequency hearing loss, rising curve, Meniere's, M for Meniere's, M for male. Always it is seen in male. Just remember, M for Meniere's, M for medical treatment. So treatment of choice, like in autosclerosis, we have stepidotomy, stapedectomies. In Meniere's, we are having medical treatment. Which medical treatment? Low salt diet. We will be giving low salt diet. So the flowchart of the treatment of Meniere's should be on your tips. Dietary modification is the first line of treatment. Then we can add diuretics. We can add steroids. If patient give you a history, if the examiner is writing the MCQ, the patient is not responding to diuretics, next will be physiotherapy, which is known as auditory physiotherapy, auditory positive pressure therapy. Patient not responding to positive pressure therapy, the next step will be endolymphatic sac decompression. I'll be going for endolymphatic sac decompression. And if the patient is not responding to endolymphatic sac decompression, we can go for destructive procedure like injection of gentamicin, where near round window we will inject gentamicin. So this flowchart should be on your tips as far as management is concerned. Examiner can show you this slide. What I'm doing, I'm putting a microvic. Beta, हम क्या दिखा रहे हैं आपको? We are showing you microvic via grommet. Can you see this grommet? This grommet, this one is a grommet. There is ventilated tube, and we have placed some microvic, a small tube with which we will inject that drug. Where I will inject the drug? I will inject the drug near round window. I will inject the drug near. I can show you any of this slide. Then any student who can make a spot diagnosis of this topic. If examiner is not asking autosclerosis, he is not asking Meniere's, then what is the third possibility? He can ask you acoustic pneumomas. So what I am showing you ice cone appearance. So what are the two keywords? Just remember the two keywords for acoustic pneumoma. Either ice cone appearance, examiner will be asking you, or he will be asking you Antony cell, Antony type 1, Antony type 2, histopath finding vestibular schwannomas. Clear? Which cranial nerve is first to be pressurized is fifth cranial nerve. Therefore, which is the earliest sign? Just remember, the earliest sign is loss of corneal reflux. Which nerves are commonly involved? Again, biggest controversy. It is inferior vestibular nerve, followed by superior vestibular nerve, followed by cochlear nerve. If examiner asks you the radiological investigation of choice, that will be a gadolinium enhanced MRI, on which I will be getting this eye stone appearance. But if examiner asks you audiometry of choice will be bad. Brainstem evoke response audiometry. So it's a tumor of 8 nerve. So it means which wave will be involved? The wave which are given by 8 nerve, wave 1 and wave 2. These are the two important nerves which will be involved. Initially, the first wave to be involved in acoustic neuroma will be wave 1, wave 2. What is importance of first wave? Is the sensitive wave. Which is the largest wave? L for lateral meniscus. Wave 4 is the largest wave. Wave 5, sorry, slip of tongue. It is fifth wave, largest wave. The 6 and 7 is inferior colliculus. Wave 3 is for cochlear nucleus. Wave 4 is for olivary nucleus. Wave 4 is olivary nucleus. What is the importance? Any student who can tell me the importance of olivary nucleus? Superior olivary nucleus complex. Any student who can tell me superior olivary complex की importance क्या बेटा? It is the highest center for stapedial reflux. It is the highest center for stapedial reflux is your olivary complex. Just remember this point. Then let us revise few important graph on pure tone audiometry. If examiners show you this type of PTA, red color, what is the red color giving you the message? Is the right side. And if there is a big gap between two graphs, it is your airborne gap. And airborne gap is a feature of conductive deafness. But isko just have this graph imprinted on your mind. This is airborne gap, conductive deafness. And if both the graphs are beyond 25 decibel, it is sensory neural. This is sensory neural. Clear? Last Central Institute examination, they have shown you both the graph. Right side graph was beyond 25. That was right sensory neural deafness. And left side graph was within 25. It was left normal. So they will ask you to combine left and right and decide the Rini's finding or Weber finding. So as far on the basis of this pure tone audiometry, the next they can ask you comment on the Rini's finding. So Rini's positive is seen in normal or sensory neural deafness. Just remember the golden rule. Rini's positive का मतलब क्या बेटा? Normal or sensory neural. Rini's negative means conductive deafness. And false negative, it is your severe unilateral sensory neural deafness. So these are 3 points. Rini's positive, Rini's negative, and false negative Rini's unilateral sensory neural deafness. Weber. If examiner asks about Weber, so just remember the golden rule. Weber is centralized in normal human being, but it is lateralized to worse ear, lateralized to disease ear in conductive deafness, while the lateralized to better ear in sensory neural deafness. Just remember. One of the students is asking me about mixed deafness. Better listen carefully. What will be there in the mixed deafness? Mixed deafness, there will be loss of amplification. So both the graph, air conduction, bone conduction, they will be beyond 25 because the cochlea is gone, like say. So the both pathways, whether it is air conduction or bone conduction, both will be impaired. But how will differentiate this from only sensory neural? In sensory neural, only sensory neural deafness, you can have amplification because air conduction is gone. Air conduction is working properly in sensory neural deafness. But if it is mixed deafness, even air conduction is gone. So the graph will be beyond 25, but there will be loss of amplification. One MCQ on the tuning fork expected, and how to make the diagnosis. What is a golden rule? Everybody should write in capital letter. Write the possibility of Weber. Write the possibility of Weber. Like Weber is lateralized to left side. So I'll be going for left conductive and right sensory. It will be left conductive or right sensory. I will write the possibility of Weber and I will rule out one. I will rule out one with the help of Renies. Renies will help me to decide whether it is left conductive or right sensitive. Every student beta in this given span, in the last spell, I will be not going in the depth of this segment. All the students who get confused in the tuning fork MCQs, just follow. Everybody speak with me. Every student speak with me beta. Write the possibility of Weber and rule out one with the help of Renies. Always try to follow this rule. You will be able to crack all the MCQs. Done? Clear? Coming to the next level. What I'm showing you, this is my maximum hearing loss at 2000 Hz. So this is your Carhart notch. But if the examiners show you maximum hearing loss at 4000 Hz is noise induced trauma. What is this one? This is which notch? This is Boiler's notch. Boiler's notch. And for noise induced trauma, what are the WHO guidelines? Indian guideline is 80, 90. WHO guideline is 85. WHO is 85. Indian Factory Act is 90 decibel. If examiner asks about city life expected MCQ, it is 45. In noise induced trauma in the industries, it is 85 as per WHO, 90 as per Indian. In city life, it is 45 decibel. How many hours? 8 hours in a day, 5 days in a week. That is same for WHO as well as Indian Factory Act. Done. Okay. So this is noise induced trauma. Then we have already learned this is rising curve. This is rising curve, Meniere's disease, low frequency hearing loss. And what is this one? This graph is coming down. This is high frequency hearing loss. That is presbycusis. That is here presbycusis. Then Meniere's and presbycusis. Coming to the next slide. Diabetic patient. If diabetic patient, here it is malignant otitis externa. Malignant otitis externa. Patient will be having granulation, ear discharge. Just remember, M for Meniere's, M for malignant otitis externa, M for that is your medical treatment. One of the students is asking whether to attempt WHO guidelines or Indian. Always remember, beta, the examiner will mention. He will, if he is giving 85 as well as 90, he will mention. Don't waste your time on these points. Examiner will give you the point. Pseudomonas is a bacteria and drug of choice will be cephalosporin. Which investigation is the investigation of choice? Technetium 99 scan. And which is the prognostic? Gallium scan. Diagnosis is technetium 99. Gallium will be prognosis. But examiner can ask you which lab investigation is used. If examiner asks you about lab investigation, it is ESR. Just remember ESR. Which surgical procedure done in malignant otitis externa? It is your debridement. We are doing debridement in the patient. Debridement. Then one MCQ expected on autoacoustic emission. So just remember autoacoustic emission by outer hair cell. Outer hair cell. They're easily damaged. They are easily damaged with any trauma, any noise induced trauma, any ototoxicity. Outer hair cell. They give autoacoustic emission. This is the best screening procedure. Clear? On which day we should do? We should do on the first day of life. They should be definitely done by first month. अगर आपने बेटा पहले दिन पे नहीं किया तो within first 30 days you should do. It should be combined with BARA. Just remember this point. It should be OAE should be combined with BARA by third month. OAE should be done in all newborns, but OE with BARA should be done in high risk baby. If examiner give you that the newborn is admitted in ICU, so BARA will be my first choice. Always remember, but BARA should be done by 3 months. And treatment, the newborn, if suffering from any deafness, he should be treated by 6 months to avoid any maldevelopment of language. If you remember, if you feel that the child should not suffer from any maldevelopment of language, we have to treat by 6 months. Just remember these important points. OE should be done on first day, should be definitely by first month, should be combined with BARA by third month, should be treated by 6 months to avoid any maldevelopment of language. High risk baby, BARA will be the first screening procedure. Then exam they can ask you on the hearing aid. Conductive deafness, beta. Just remember, conductive deafness, treatment of choice, first line is always hearing aid. This is BTE, behind the ear. This is CIC, completely in the canal. And this type's bigger than CIC, smaller than BTE, bigger than CIC. This is your ITE. Just remember, beta, this is your ITE, in the ear hearing aid. So they can ask you to identify the hearing aid. If they show you something on mastoid, only on mastoid, there's some hearing aid, we call it as Bahl. Bahl is indicated for canal atresia. Like when there is a canal stenosis or canal atresia, we use bone anchored hearing aid. Done. Expected MCQ on this topic. Then they can ask you on cochlear implant or brainstem implant. Sensory deafness, what is the golden rule? Sensory deafness, the treatment is your cochlear implant, and neural deafness, it is your brainstem implant. Where we keep the cochlear implant, we keep the cochlear implant in scala tympani via round window. Root 2 MCQs, revise with me. Cochlear implant is kept in scala tympani, kept via round window. Brainstem implants, they are kept in lateral recess of fourth ventricle. They are kept in lateral recess of fourth ventricle. Then cochlear implant stimulates, they can ask you, it stimulate eighth nerve. Brainstem implant stimulate, they directly stimulate cortex. Clear? So these are the important points. I am showing you one slide. If they give you some image based MCQ, they can ask you something on the parts of hearing in this cochlear implant. So beta, this slide is very crucial. They can ask you the parts of cochlear implant, brainstem implant. Then coming to the next one, which investigation is being done. I am showing you some electrode capped on sternocleidomastoid ear. This is VEMP. What is a VEMP? Vestibular evoke myogenic potential. VEMP, vestibular evoke myogenic potential, is of two types. One is cervical, one is ocular. Just remember, VEMP, vestibular evoke myogenic potential, it evaluate which part of the cochlea. Expected MCQ for NEET, it evaluate saccule. Just remember, VEMP, vestibular evoke myogenic potential, it evaluate saccule. Which part of the inner ear? Saccule. Cervical is related with ipsilateral sternocleidomastoid. Ocular is related with extraocular muscles. Sternocleidomastoid ipsilateral, it is inhibitory response. This is excitatory response. Then it stimulates saccule. It is of two types. One is ipsilateral sternocleidomastoid, one is here extraocular. Now, if examiner ask about superior semicircular canal dehiscence syndrome, investigation of choice will be VEMP. Superior semicircular canal dehiscence syndrome, the investigation of choice will be your VEMP. These are the important points which should be on your tips related with VEMP. Coming to the next slide. Yes. What I'm showing you now? I'm showing you some positional exercise. What is this one? The patient, the topic dedicated to BPPV, benign paroxysmal positional vertigo. This topic related with BPV, but the word BPV give you the message. In this patient, only vertigo beta. Just remember, kaam ki baat, hearing loss is not there. There is no hearing loss. There is no CNS symptom. There is no hearing loss. There will be no hearing loss. There will be no CNS symptom. Benign paroxysmal positional vertigo. What the word benign give you the message? Benign give you the message it is only few seconds. So it is for very few seconds. The patient is getting vertigo in a position, head position. I label it as BPPV, benign paroxysmal positional vertigo. What is the investigation of choice? Investigation of choice is Hall-Pick maneuver. Beta yaad rakhenge, Hall-Pick maneuver. And treatment of choice will be a positional exercise, that is Apley's maneuver. Apley's maneuver. Now, what is the difference in Hall-Pick and Apley's? The first three steps. If I ask you what is this first three steps, this is your Hall-Pick maneuver. This is Hall-Pick. And if I ask you the complete cycle is Apley. So in a layman language, I can say Apley's is nothing but first three steps of Hall-Pick is nothing but first three steps of Apley. First three steps of Apley. Am I understandable? What are the other important exercise? Examiner can ask you thereof, thereof. The patient is sitting, then lateral position, then again sitting back, and then like lateral position. That is a circle, four position. There are four positions are there. Again, I'm repeating, beta. Patient. If examiner show you something like patient sitting, then right lateral, then again sitting back, then left lateral, the complete cycle is known as thereof exercise. If they show you some patient facing to the floor, facing to the floor, then ceiling, facing to the floor, then ceiling, that is Foster. That is Foster. And if examiners show you a three position exercise in which the patient is sitting, then lateral, and from right lateral, the patient is going directly to the opposite left side lateral, that is known as Simont maneuver. That is known as Simont maneuver. So these are the important points, exercise related with here BPV, benign paroxysmal positional vertigo. One MCQ expected on this topic, so better please revise it properly. Once more important point which I want to discuss with you is tracheostomy. This topic is left, so let us discuss few keywords. Last slide of the topic. Listen with tracheostomy, which is the best area. It is between second and third ring. Second and third ring. Listen carefully. High level tracheostomy. If the examiner asks you high level tracheostomy, it is done for. High level tracheostomy is done for. Reply everybody. Last slide of the session. Every student should reply. It is between second and third. I want every student sitting with me should reply. High level tracheostomy done for malignancy. Low level tracheostomy. Low level tracheostomy is done for infection. It is done for infection like diphtheria. Any student who can tell me what the importance of diphtheria? Diphtheria membrane on the tonsil, it will bleed on removal. Diphtheria, we do low level tracheostomy. And just worth remembering point is your bull's neck. Bull's neck is a feature of diphtheria. Just remember this one. Clear? Now, vertical incision. Vertical incision is used in tracheostomy in emergency. If examiner asks you about emergency, it is vertical incision. And horizontal incision is used for elective procedure. It is used for elective procedure. Then examiner can ask you dead space. If you are doing tracheostomy, your dead space is reduced by 30 to 50%. I'm expecting one MCQ on tracheostomy. I'm teaching as last topic, beta isko yaad karna, revise karna. 30 to 50% dead space is reduced. Dead space is reduced by 30 to 50%. Just remember this point. After how many days proper track is formed? So proper track, the track of tracheostomy tube is formed by 7 to 10 days. After 7 to 10 days, there is very less chance that the track will collapse. Clear? Then examiner can ask you which is the best tube. Always remember, cuff tube are the best tube. Cuff tube, because they reduce aspiration. They keep the tube in position. What is a drawback? Only one drawback is pressure necrosis. The patient may have pressure necrosis. Therefore, how frequently, examiner will ask you, how frequently you should deflate the cuff. We should deflate the cuff every 2 hourly for 5 minutes. Every 2 hourly for 5 minutes, we should deflate the cuff. Examiner can ask you which of the following tube is best for voice. So examiner, if the examiner is showing some tube on which there is a small opening, we call it as fenestrated tube. So yaad rakhenge beta, fenestrated tube. What is the use of fenestrated tube? Fenestrated tube is used for voice, vocal rehabilitation. We use fenestrated tube. Then if you place the tube and after few hours tube is blocked, now there is a blockage. the tube is blocked. So two possibility, either it can be complete blockage, or it can be partial blockage. If it is a complete blockage, what is the treatment? I'm waiting for a response. If it is a complete blockage, तो बेटा क्या करना है? Remove the tube immediately. And if it is partial blockage, I can do suction with the help of normal saline, normal sodium bicarbonate, sodium chloride. We can do suction. ENT secretion like nasal cavity, atrophic rhinitis, we clean with the help of sodium chloride. So these are the important MCQs related with your tracheostomy tube. MCQ expected, so please read the topic in a nice way. Clear? I tried my best to touch all the important topics, and take my word, beta, last few days very crucial, no negative thought. Work 24/7, do or die situation. We have to be on the other side. Make your parents proud again by playing the best game. Beta, आपके parents ना आप में blind faith करते हैं, and they keep blind faith on you, your performance. And take my word, beta, we will not lose dedication, we will not lose the momentum in the last spell. Last few days, we will not have any phobia, beta. No phobia should be there. अगर game हार भी गए तो कोई बात नहीं. We should not have any regret कि we have not given best performance. We should give our, I always say, give your 110% in the last few days. We all are praying, beta. Students are asking to pray for us. We all are praying for you, beta. Just try your best to get a good rank in your upcoming examination. Even then, just this phobia of losing the game should not be there. Even if you lose the game, beta, the best degree, MBBS degree, is with you. You are doctor, beta. That word doctor is there in front of your name. So just remember, beta, this is a golden opportunity to make our parents proud. And work 24/7. Any query you can ask in our Telegram group, you can ask on the Extosic Club, you can ask me on Instagram. But in the last spell, don't waste your time on those topics which you have not read. Forget, leave it, leave everything. Just whatever you have read, revise it nicely. Last one day, just relax, have a sound sleep, go to the examination hall on time. I will advise you to take your parents or your elder brother or sister with you. Just keep a cool mind, give your best performance. Clear? Thanks a lot. We stop at this point, and I'm confident I will call you all people for the interview in our Delhi center, and we'll have again one interaction. Thanks a lot. Best wishes.